Speaker to the audience.
Josephson. She's a Hawkins Family Endowed Chair of the Cancer and Blood Disorders Institute and Clinical Division Director for Hematology Oncology at Johns Hopkins All Children's Hospital, St. Petersburg, Florida. Department of Oncology, Pediatrics and Pathology, Johns Hopkins University School of Medicine. Her research focuses on pediatric transfusion medicine, particularly transfusion therapy in neonates, sickle cell anemia, thalassemia, and massive transfusion in pediatric hemorrhage. She's principal investigator on multiple grants from the U.S. National Institutes of Health, U.S. Centers for Disease Control, industry, and private foundations. She's associate editor for Transfusion and has co-authored over 200 peer-reviewed journal publications, review articles, chapters, and books, and is co-editor of the textbook on the bleeding pediatric surgical patient. She's co-chair of the REDS for Pediatrics program, evaluating the recipient epidemiology and donor evaluation of blood products and transfusion in the US and Brazil. She's recipient of the 2024 Emily Cooley Award from the AABB for outstanding mentorship, teaching, and contributions to pediatric transfusion medicine. We invite you to deliver your talk today.
Thank you very much for that kind introduction. I'd like to thank the organizers, especially Sajam, for inviting me to come and speak. I feel extremely honored to be here. Yep, you got it. So the capacity in which I'm going to speak today is as the co-chair of the REDS 4P program, because I'm going to be speaking about a vein-to-vein database from the donor to the recipient and how that is incredibly useful, especially in neonatal and pediatric transfusion. You're okay. Not down there. Oh, doesn't want to, huh? That's weird. Okay, yes, no problem. Thank you very much. So, so as I was saying, so that is the capacity in which I'm going to be speaking in the context of things. Just so you know, like where I'm located, so you may know about Johns Hopkins School of Medicine. It's located in Baltimore, which is up in the northeastern part of the United States. This is the 6th hospital that the Johns Hopkins Medicine has purchased. And in 2011, it was a freestanding children's hospital in Florida. And the other hospitals they have up in the Northeast are not freestanding, such as this. And so it is a very different experience being obviously in a children's hospital where there are no deliveries, but many, many sick patients are transferred in, and tertiary care and quaternary care takes place there. But like I said, I'm not speaking about that today. What I am going to speak about today is the REDS research program, which you may have heard about. It's been around since the late 80s. And basically, the programming sponsored by the National Institutes of Health and the National Heart and Lung and Blood Institute within there. The goal ultimately of these programs over these many decades has been to improve the safety and availability of transfused blood products, both in the United States and internationally. And it started with retrovirus. So the R used to stand for retroviruses, and looking at the epidemiology within donors, not really the recipients per se, but what the risks were of those. And as time went on, it expanded past the United States, Brazil, and China were included in the REDS 2 program. But it wasn't until 2011 where it went from looking at the actual donor and the retrovirus to more of the recipient. So the R stayed the same, but it was more of the recipient epidemiology and the donor evaluation study. And up until 2016, which is when the end of the REDS 3 program, pediatrics was not really a focus at all. There were some children, and I'm going to present some data from there, but they were not the focus of these databases that were built. There was plenty of information coming out, but really, how are we going to apply that to children? And so the NIH said, well, it's time for a study in children. And that's when the REDS 4P was sort of born. And in 2019, it came into play. It involves 4 hubs, and these are geographically dispersed in the United States. There is a blood center at each, it's at the hub of each of these places, and the hospitals that are supplied by that blood center are again part of it. So you can have a linked donor recipient study, but it isn't just one study, and I'll show you that in a second. But the real key here was making sure we captured blood administration, blood products that went to children. And you all know how difficult that is, because you can have one donor and you can have that blood go to many recipients, because aliquots are made from that. And it's extremely hard to follow. We had 22 hospitals that are involved in this, and we have 6 freestanding children's hospitals. Again, a very big difference. This slide is just to show you the demographics again in the United States. Brazil is also involved in the study, and mostly we're studying sickle cell disease there. And I'll show you where some of that overlap is, but I'm mostly going to concentrate on the United States. We have a data coordinating center, which is WESTAT, and they have been building what I am going to talk about as that vein-to-vein database, with networking all of these hospitals and all of these hubs together for the first time in a very comprehensive and innovative way. This is a picture to show you all the people, because this is right before COVID hit. So we actually were all able to get together in 2019. And there is a publication that sort of explains the blueprint of what we are doing in this program, but I'm going to give you the specifics. Again, this study involves Brazil and the United States. There are actually 5 hemocenters that are involved in Brazil, and again, mostly focused on sickle cell disease. That is the encompassing part of pediatrics, but also arbovirus is looked at, dengue is looked at, and so that rapid response, COVID was looked at. We're in the 6th year of this 7-year program, so we're at the very exciting time where many of the studies that have come to maturation are now being analyzed. All of the data has been collected, and so there's going to be a huge output in this next year and the following 2 years of what has happened in this program. So what is this program? Well, in the United States, the main focus was to build this huge vein-to-vein database, which is sort of the background that's up at the top of the slide. And it encompasses everything from the blood donor, about anything about the donation, what machine was used, say for an apheresis, red cell collection, is it whole blood, et cetera, all the way into the hospital blood bank, what kind of manipulation we do to the product, and then who the recipients are. And so that is sort of the basis for many of the projects that were being done. There's 2 large prospective multi-center studies that I'm going to show you. One has to do with preterm infants called TIPI, and another one has to do with chronic red cell transfusion in patients with sickle cell, thalassemia, and some who have hematologic and oncologic problems. But some of the main outputs that we've been able to do have been data analyses of different epidemiologic studies in different groups of children. So while we were building the REDS 4P database, which I'm going to go into detail, we actually have a huge output from the vein-to-vein database, the linkage between the donor and recipient for neonates, peds, hematology, oncology patients, and cardiac surgery patients. And so we squeezed all the data we could find that wasn't truly collected for children in the REDS 3 version of REDS, and then wrote many papers about it. And just to give you some insights of what you can do with a database that's like this, we started to look at variations in the neonate. We started to look at a large hospitalized cohort of children who were in the pediatric ICU. We looked at the cardiac ICU. Again, we looked at hem-onc patients, and we presented many of this information at different meetings and then have now been in publication. But this is the kind of specifics that you could get. You can find the incidence of transfusion by gestational age. And of course, we were able to see that red cells and platelets are the number one products given, especially to the smallest babies. But we were also able to look at hemoglobins. And this is sort of, we don't know if it's the threshold at which they were transfused at, but it's the hemoglobin 24 hours before they were born. And if you go into, before they were transfused. And what is really interesting about this is that you can sort of look at different hemoglobin levels at different gestational ages. And remember, this is before the top trial that Simon just showed and before the Etno trial. So this is really the PINT study and the Bell study, which he also showed, which really got people thinking that you needed a more restrictive, and people went very restrictive in some of these groups. And what we were able to see is that there were people in the low, people in the high, but there were a lot of patients that were transfused under 8 grams per deciliter. And that was around the time where people were finding more and more necrotizing enterocolitis. And there were many, many reports. And so the question was, is anemia sort of contributing? And that was one thing that people could actually now see, because those were some of the practices. Another thing that was looked at was hematology and oncology patients in the US. And this was over almost 5,000 encounters between 2013 and 2016. And you could sort of see through this Venn diagram what products were being transfused, what products were being transfused together. You could also break it down by what the disease is, whether it's outpatient or inpatient, and you can see we've got neuroblastoma patients and what some of those thresholds were that people were having before they were transfused. You could break it down by the diagnosis, and they could do it for platelet counts. You could do it for INR. This is just to demonstrate, again, how powerful this kind of a tool is. We did it in the pediatric ICU, and we were able to tell where the patients were actually transfused, which is very important for targeting, speaking to those physicians about whether the transfusion is appropriate, inappropriate. If you don't know where they're transfused, you can't really go there. But also trying to understand what exposures are happening where in the hospital. And finally, with congenital heart disease, you could see where, again, whether it was ordered preoperatively, whether it was intraoperative, and whether it was postoperative. And those are very important things to understand, because the way the blood bank works and whether it's happening intraoperatively, can you actually prevent some of that intraoperative, oh my God, we need to prepare blood. Can some of that be done preoperatively, et cetera? So the innovative thing about the way we built the database in the REDS4P is that it was built knowing that we had these discrepant databases. Of course, you probably think to yourself, well, how could you possibly tie all these databases and build an interface and do all these things? But there is something called the Observational Medical Outcomes Partnership, which is a common database language. So people went and spent time trying to find some common language that could be the interface between discretely made databases. And in doing that, you could tie together the donor database with the donation part of that database, the hospital transfusion, and the electronic medical record. And in doing that, and it's never been done with blood before, it's been done with other databases, especially government databases for payers and different things like that. And this is in the US. But there is medical terminology. And what they were able to do was get agreements with all of the hospitals and get them to say that we were going to keep everybody's data private, and that it was going to be protected, and that we could bring it all together and sort of understand it in every single one of these discrete places. And I know that sounds like crazy, but we actually were able to pull it off. And when you pull something like this off, it is incredible the kinds of questions you can ask. And we were able to get 2.3 million donors pulled, and you can see all the information about those donors. What medications did those donors take? Whether they were male or female, were they vaccinated, for COVID? What's their BMI? A whole bunch of health history. When you go to the donations, you can look at all these characteristics, which we all think about on a continual basis. But even if you had a red blood cell antigen typing, we could tie that together. And then finally, we have over 8 million blood components, and you can see all the different pieces, expiration dates, product type, et cetera. And then we plug that into the electronic medical record of the patient. And with this common database, you can extract all of the information. You don't have to say, well, I want to see if this is a boy or a girl. I want to see what their weight is. I want to see. You don't have to ask that. It actually brings all the information in from the electronic record, and then you create what they're called is value sets, and you do validation of whether that data is complete or not complete. And so this is what we've been working on for the last 5 years. So it's pretty exciting. And some of the high level statistics that I can just kind of point out to you here is that from a patient standpoint, we have 1.1 million patients and 20.6 million healthcare encounters, 2.5 million inpatient encounters, and 1.9 million transfused units or aliquots. And you can see this breakdown of the red cell aliquots, which is very hard to trace. Right? This makes pediatric and neonatal transfusion, especially neonatal transfusion, very hard to study. And so being able to have this captured is huge. Also having the mother-baby linkage, we made sure that we validated we could do that because there are many things, Nate, hemolytic disease in newborn, all the alloimmunization stuff, everything we talk about, having this be able to be tied together. So when you go to look at the children, you can see here, and this is the biggest we've ever had in the United States. I'm sure it pales in comparison when you think about all the patients you have here, but just imagine harnessing what you have. We have over 400,000 inpatient encounters and over 2 million outpatient encounters. And I'm not going to quote all these numbers, but to show you we were able to break it down by inpatient, outpatient, and then stratify by how old the patients were. And so really getting down to some major detailed information. Now, what are some of the studies that we've been able to do? And I can't go through all of them because I only have 25 minutes, but I wanted to tell you that two of the big studies that are going to be coming out very soon is a donor and platelet concentrate characteristics and their association with transfusion efficacy and clinical outcomes in pediatric and neonatal recipients. And actually, Ruchika in the front is leading that charge, and we are really close to submitting that paper. So it's very interesting data that will be coming. We're also going to be looking at health disparities and fetal maternal outcomes in women receiving peripartum blood transfusions. And so this, again, that linkage between not only the mom and the baby, but having the linkage between the donor and the recipient and what that effect is on the child is going to be coming out of that study. And we've just now made all of our study groups to be able to study the following questions, which are really exciting, which is looking at bleeding in very low birth weight infants and pre-transfusion platelet counts. We're also going to be looking at the determinants of hemoglobin increment and transfusate hemoglobin in patients who are chronically transfused with sickle cell disease. And this will happen in Brazil and the United States. We're also going to look at hemolysis and infection in transfused patients. And finally, we're going to look at something that was mentioned a little bit earlier, which is about those anticoagulant preservative solutions and what their actual effects are on the neonate. So we can look at rate. We'll be able to look at what product, and we have a lot of different products that neonates can receive. It isn't just with SAGAM. We have AS1, we have CPDA. We don't even have SAGAM in the United States. We have AS3. We have all these different additive solutions. And in small volumes, it seems that it's okay, but we're going to actually be able to look at large volume transfusion and be able to calculate, what the actual constituents of those solutions are and what the effect is in the patient. So that's ongoing right now. We did focus on transfusion reactions because we knew we don't have a good hemovigilance program in the United States. It actually stinks. So compared to shots, very bad. So what we did here was not really to to create a hemovigilance program, but we wanted to do a study where we could sort of look at transfusion reactions prospectively during these 5 years. And so not only did we grab stuff from the vein to vein, but we also had adjudication by people at the different hospitals to see the imputability, all the different pieces of that adjudication that takes place at each hospital, and record that in addition to what we can pull from the vein to vein. And I'll show you some very clever things we can do. The one thing I want to show you is that we were able to show with this, the first aim, that there is a 2.6-fold higher rate of transfusion reactions overall over adults. And it was pretty statistically significant. And this is looking over 235,000 blood products transfused to over 22,000 children. These transfusion reaction rates ended up being around 415 per 100,000 transfusions. And they primarily occurred in red cells and platelets, which are not surprising. What we were able to do is look at, this is the most transfusion reactions that we've been able to, and this isn't a single center, right? This is the whole group of patients that are being looked at all the 4 hubs and all the hospitals, 22 hospitals. And you can see that the most common transfusion reactions were allergic, febrile non-hemolytic transfusion reactions, and then TACO and TAD and trolley were, much further down. And so what this brings you to think about is, well, how severe are those reactions? We know from other studies, we know febrile non-hemolytic and allergic seem to be the most, frequent, but how bad is it when you have those? And really, we found that they were not very severe. So that was, pretty interesting, and again, validated with many places. But the real question is, other things that we worry about, which I'm going to point out, which is how we give that transfusion. So one of the things I wanted to point out, besides, we know that there's more transfusion reactions in kids than adults. We know what they are, but we don't really know whether the TACO, trolley, and TAD rates are true. And we know all transfusion reaction reporting in adults and peds is underreported, right? Because we wait for the clinician to say, oh, I think this might be related, and then it comes back to the blood bank, and we try to figure it out. And if they don't know that's in their differential, they're not going to send it back to the blood bank. But what we don't know in children is we have a lot of adult definitions that are being applied to peds. And maybe, I don't know how many you get, but for neonates, how many transfusion reactions do you really get reported in there? Like 0. Does that mean there are no transfusion reactions? Probably not, but it's just not attributed to it by the clinician, so it doesn't get reported. So the question is it really the definition correct? Are people recognizing it? And is it ever going to change? Because we try to educate all the time and it really doesn't change. So I'm going to suggest something that is pretty cool that you can do with a vein-to-vein database, is you can do an active surveillance before and after every single transfusion, because with the vein-to-vein database, you can get the vital signs. You can get how much oxygen the patient was on. You can start to look at things without asking the clinician. And I'm not saying the clinician isn't important, because obviously we know they are, but it is really important for us to know there may be signs that are not being picked up on that we may see that actually may be important. And I think what Dr. Stanworth just showed us at the end, the very end of his presentation, there are downfalls to potentially how much blood we give. We don't even know that unless we're looking at the physiologic changes. And some of those you can't really pick up by the way you see the patient now. It's by some of the monitors and things. So this can act as a help, a tool, a liaison. And what we're going to do is try to demonstrate that. But you first have to know what the passive surveillance rate is, which we have calculated now. And now we're in the process of doing the active surveillance rate. So again, this is a plug for how important a vein-to-vein database can help you. Two of the other things that we were able to do, which weren't these retrospective questions that I just presented, but we were able to do 2 large prospective multi-site protocols. Again, this is just kind of epidemiologic and with no interventions here, but we were able to study in preterm infants looking at their blood utilization, transfusion practices, and clinical outcomes. And we were able to tie the Vermont-Oxford network, which is a complete database in the United States that collects all the information about preterm infants except for transfusion. The only thing it doesn't collect, collects everything else. And we were able to tie those two databases together with the OMOP that I was just explaining. And the other one is looking at red cell transfusion chronically in sickle cell thalassemia and some hem-onc patients. So some of the things I just want to point out in, we don't always think about it, is all those things that you can collect from the donor all the way to the recipient and sort of really have it stand out for that preterm infant. And what is the things that we're looking for in a composite outcome are all those comorbidities of being preterm: neck, retinopathy of prematurity, moderate to severe BPD, interventricular hemorrhage. And so this is kind of a all-in-one statement as opposed to a single center, which again, many of the studies, including the one that we did on necrotizing enterocolitis, it was 3 hospitals, but it was 1 center. The other cool thing you can do with a vein-to-vein database is you can look at implementation science. And that was one of the cool things we were able to do. So it was nice that Simon introduced the ETNO study in the top trial, showing those, threshold studies. And we started to say, well, we can look at this over time because we had already pulled all this data. And we were actually able to show that there was a decrease in the hemoglobin drawn, 24 hours before, because we don't know if this was an exact threshold, but it seems like transfusions were happening at lower transfusion thresholds for hemoglobin, and they were statistically significant drop in those hemoglobins. And then we looked at it based on, different years, and we could see the first week of life, the second week of life, and the third week of life per each year. And you can see it goes down as well. And so we're not absolutely certain, but we're sort of coming along thinking this is probably due to the changes in the randomized control trials that were presented and actual changes within those units. But interestingly enough, when you look at the Planet 2 study, which is our transfusion thresholds, we actually don't see a difference at all. I see him, he's frowning down there. He's very sad. And believe you me, we're sad in the United States too, because we don't really understand why there seems to not be a change, but there hasn't been. And we looked at, exactly the same population. We looked at 142 extremely low birth weight infants with at least 1 platelet transfusion, and there were over 600 platelet counts looked at to make this graph. We even went further and we tried to look at per week, first week and second week, because there are different thresholds there that were defined, and again, found no difference. So extremely disappointing. But again, a way to use this. There are other ways to use the use a vein-to-vein database to our advantage. We don't understand about plastics. We don't understand how that may be influencing the patient. We don't understand whether the rate at which we transfuse the patient is part of the issue. We don't know about dose because we don't do it by platelet. We do it by volume. And we know how inaccurate that can be when you're trying to draw that out of a parent bag. So there's many things that we can tie together by creating a vein-to-vein database in questions that we don't know the answers to. And finally, the red blood cell impact study, which is really quite interesting. And so here we did a 2-year study of patients who either had who were chronically transfused every month, either with thalassemia or sickle cell, and we weren't able to get as many as we want who were peds hem-onc patients who were inpatient. All of the other patients were outpatient. But we were trying to assess how the donor component and recipient factors contribute to the red blood cell efficacy in the chronically episodically transfused patient. And, one of the things you can do is you can look at the hemoglobin change for hemoglobin S when you're given hemoglobin A. We can look at the delta hemoglobin, and that's what we looked at. But we also can look at contributing factors that we did some precision transfusion medicine arrays on the donor blood, looking for oxidative and osmotic hemolysis markers that are actually inherent to the donor. And that is being done both in Brazil and the United States. So we're trying to look at all different factors that may be influencing how long the blood lasts in the recipient from transfusion to transfusion. And we're actually trying to make sure we have the right number and power to be able to look at a bunch of different alleles that could be affecting the patient. And so some of those things on the array are here. So it's not just about those hemolytic markers. So this is going to be part of the database. There's alloimmunization variants that are going to be collected. There is background ancestry information that we're going to have, HLA. So there's going to be a myriad of things that we're going to be able to look at from the donor to the recipient that is going to be hopefully insightful to all of us to understand why sometimes blood doesn't last as long in certain patients when we transfuse them. And it isn't all about the storage age or, maybe the biologic age of the unit. There have been multiple publications, and I'm not going through them all, but I am going to leave this slide set with you all because it goes through how the vein-to-vein has been used in other ways besides what I presented here. I tried to keep it all pediatric. There's many manuscripts that you can see, many meetings that these have been presented at. But I would say that the most important thing I want to leave you with is that you all have really important information that you're sitting on here. And if there is a way to tie everybody together, we can look at some of those epidemiologic factors because you can't make a randomized control trial. And we've made this mistake in the United States a lot, trying to say we need this high level of evidence, but we really don't have enough of the baseline information to know whether there's equipoise, to test two different things, because we don't even know whether we have enough power to answer the question, or we don't even know where the real problem is to actually make a power calculation. And so I would say that some of this work is really foundational to be able to build upon, to go to that evidence-based medicine that we all want really to drive the practices. And the only other thing I want to say in general is optimizing transfusion is the way I try to look at transfusion. I don't try to look at how little blood can I give a patient. I want to give the right amount of blood for what that patient needs to be able to survive and thrive. And that's in all different populations. And right now we rely on some of these, one-dimensional laboratory results where we have to move away from that. We obviously are looking ourselves at the patient and the clinicians are looking at the patient, but there has to be more because we know that the hemoglobin, the platelet count do not determine what is eventually going to happen. And we have to make critical decisions every single time we want to transfuse, but we have to do it in a way that isn't going to harm the patient by withholding, but also isn't going to harm the patient by giving. And so we constantly need to be thinking about how we can do it the best way. And so I thank you for your attention and ready for any questions you have. You're welcome.
Thank you very much.
Okay.
I think can the mic on. Very much.
You're welcome.
Mic is working. Yeah.
Yeah.
It was an excellent presentation.
Thank you.
On the enormous data which you have, from the donor to the recipient, really vein to vein, and it's kind of generated so much information, and you got, done a tremendous amount of retrospective data analysis, and the kind of questions it has generated, your prospective multi-site protocols and other trials. So I think it's really very essential for all of us to think in terms, of course, that's extensive, ideal, and for people sitting here, it's like a dream. But then we do need that kind of a setup, and I think at least institutional, we could start looking at that kind of data ourselves, and that is what is really going to give us evidence-based transfusion medicine. And I really like the way you ended, optimizing. And we're not going to get, restricted on the restrictive aspect or the liberal, but optimization is the goal. Thank you.